The internal jugular vein. The internal jugular vein is the most popular site for central vascular access on the planet. Certainly the IJ vein is the vein of choice for patients with chronic kidney disease. Today we are considering the IJ approach for non-tunneled acute central venous catheters. There are many different approaches to cannulating the internal jugular vein. However, we must bear in mind the two principles underlying our practice. We have to do what is right for the patient, not what is convenient for us. We have to make it easy to do the right thing and hard to do the wrong thing. This discussion of internal jugular vein access will start at the end with the dressing. Take a look at these examples. Whenever I round in an intensive care unit, I find something similar to these photos. These are examples of insertion that is done for the convenience of the inserter, the 1% of the life of the catheter, not what is right for the patient. If our goal is a proper dressing so the nurse can provide proper care and maintenance, then there are certain techniques that should be utilized. The insertion site should be low in the neck and the catheter must be rotated downwards. In discussing the low cervical approach, there is considerable resistance from some physicians over the low approach. Generally, their argument is that a mid-neck or higher approach will protect against pneumothorax. While this may be true, the mid or high approach certainly leads to improper dressings which are associated with an increased chance of infection. I maintain that the primary defense against pneumothorax and the other insertional or mechanical complications is to learn how to follow the needle with ultrasound. The next controversial change that I will ask you to make is to approach the patient and the internal jugular vein from the side of the bed. In most hospital rooms and intensive care units, the head of the bed is cluttered with equipment such as oxygen, suctioning, monitoring, and electrical cables. It can be very difficult to get to the head of the bed and maintain a sterile environment. And maintaining a sterile environment can be challenging. Be a major proposition for me to get to the head of the bed on this side of the bed. Making room at the side of the bed is relatively easy to accomplish. You can see the side of the bed has much less equipment, oxygen, electrical, suctioning equipment, and the lines. So we believe in coming in from the side of the bed. It's easier to maintain a sterile setup if you come in from the side of the bed. So far, I am strongly recommending that the inserter approaches from the side of the bed and punctures the IJ low in the neck. The next item I insist on, the inserter must rotate the catheter downwards toward the chest. We're going to fold this thing down toward the chest, not up near the ear. Okay, I do not want this dressing up near the middle of the neck. I want it down toward the chest where it belongs. Right, so we're going to on with the slit facing the catheter, and we're going to offset it of just a small amount, maybe about 10 degrees. We have the catheter down. All right, we're going to do the skin prep. Okay, so we're going to take off the rest of it. You cannot have a dressing on the mandible or the ear and consider it modern vascular access. The neck has much greater motion than the chest, and motion isn't good for dressing stability. Now, we are approaching from the side of the bed for a low approach. We find that the in-plane approach, using the long axis of the probe to a transverse, the ideal method to accomplish all the safety goals of an IJ insertion. The IJ line will be low and rotated downward. The in-plane approach allows for a gentle curve. These details will maximize the chance for the patient to have an intact dressing for up to 7 days. Some physicians have voiced their concern related to the in-plane approach because the trajectory goes from lateral to medial, thus endangering the carotid artery. Again, the primary defense against inadvertent carotid puncture is to visualize the path of the needle with ultrasound. The remaining techniques of modern vascular access are: A. Do not cut the skin. The skin is the natural barrier to infection. I never cut the skin for catheters that are 12 French or less. If you don't cut the skin, you get much less bleeding, and blood and dressings don't mix. In summary, Modern vascular access dictates changes to the internal jugular approach as it was originally described. The practice of inserting from the head of the bed, high in the neck, and placing a dressing near the mandible or the ear must be abandoned because they are not the right thing for the patient. Instead, the insertion should be low in the neck, the side of the bed is advantageous, the catheter must be rotated downward so the dressing is on the chest or the supraclavicular region. The skin should be respected by not incising or suturing it. Antimicrobial catheters, chlorhexidine sponge dressings, and skin adhesives will reduce infectious complications.